So just a few updates here before I introduce our honorable speaker. We have our seed funding for the fall of 2022 for the Dunlevie Center is now accepting applications with a deadline of receipt on October the 3rd. And we're looking forward to reviewing these applications as they come in with our team of reviewers. Looking forward, we have many exciting presentations for the Dunlevie monthly lecture series, with the next in September. Our very own Yair Blumenfeld will be presenting fetal lower urinary tract obstruction and his development of a novel fetal bladder shunt with our biodesign colleagues. Okay, I think we can go ahead and start, and I thank you all for joining. I am absolutely delighted and honored to introduce dear colleague, Dr. Alan Tita. Dr. Tita is the John C. Hoth Professor and Senior Vice Chairman of OBGYN and Director of the Center for Women's Reproductive Health at the University of Alabama Hirsink School of Medicine. He obtained his medical degree from the University of Yaoundé in the Cameroon and received specialized training in medicine and public health in the United Kingdom at the University of Leeds, and in the US at the University of Texas, Houston, at the Baylor College of Medicine, and at the University of Alabama. He practices maternal fetal medicine and conducts research to improve the health and survival of mothers and their infants globally. He also serves as Associate Dean for Global and Women's Health at UAB. Dr. Tita is truly a leading figure in the field of maternal fetal medicine, with over $50 million in funding from extramural sources since 2009. In 2018, he was ranked as the #1 NIH-funded OBGYN investigator. He has authored and co-authored nearly 300 peer-reviewed papers, among them studies which have changed practice nationally and globally. He was on the subcommittee of the practice-changing ARRIVE trial, which was listed in the New England Journal of Medicine's Drazen's Dozen for articles that changed practice since 2000. His work on elective delivery before 39 weeks helped shape national guidelines regarding early-term delivery. And now, most recently, the results of the chronic hypertension in pregnancy study, which he will be discussing today, has resulted in a change in ACOG recommendations around the treatment of chronic hypertension in pregnancy. Alan, welcome to the Dunlevie Center monthly lecture series. It is a pleasure to have you here with us to discuss insights from the Chronic Hypertension in Pregnancy Project.
Yeah, no, thank you so much. Yes, it's great to be here, and I can't help not noticing Dr. Gibbs. It's been a while. Oh, wonderful, great to see you.
It's great
So,
to be here.
hi everyone. I mean, lots of friends already I see on the call. I'm just going to go ahead and begin so that we make great use of the time. I had some background information about chronic hypertension, which I'm going to go over rather quickly, so we get to this section on CHAP. So let me go ahead and share the screen here and put this on. Is this good?
Excellent.
All right, terrific. So, yeah, so I just wanted to talk a little bit about, just some of the mundane background, classification, epi in pregnancy, treatment guidelines, and then bring it home with some of the information that you have seen with respect to CHAP. And I'd like to start with the Joint National Committee number 8 document, which at the time that we were designing and frankly getting CHAP started was the main go-to document for the management of hypertension outside of pregnancy. And essentially, this document, had about 8 main recommendations and said the threshold at which to treat 140/90, and the goal of treatment was less than 140/90. So that's where we were. Other recommendations about, what medications to use, etc. This map, I think, is just to say the deep red indicates states where the prevalence of chronic hypertension is highest. You can see a lot of preponderance around the southeast here, and many of the CHAP sites also came from these areas. The SPRINT trial is also a precursor to CHAP, because at the time we were designing this, we knew it was going. One of the leaders of the SPRINT trial, Dr. Susan O'Parrell, is been a long-term leader in hypertension outside of pregnancy and was one of the leaders of SPRINT. And as you know, SPRINT is one of the trials that led to a reduction in the goal or threshold for treatment in some instances, and certainly a reduction in the goal for treatment in patients with chronic hypertension, highlighted in the 2017 ACC-AHA document shown here. And essentially what this document says in the last column here, 2017, for 2017, saying everything above really above 130 systolic and above 80 diastolic would constitute hypertension. So stage 1 hypertension being that window, new window below 140/90, which I think for the most part we still use in pregnancy. And then what was the impact of this? As you can see on the left panel, a 50% increase overnight in the prevalence of hypertension in the general population, from about 30 to 45, 46%, and in numbers also 70 million to over 100 million with hypertension in the US. This pretty much summarizes, treatment BP thresholds and treatment recommendations, and brings into the fore the concept of ASCVD, the atherosclerotic cardiovascular disease score. And if that's 10% or greater is considered significant, and that's where treatment is recommended for those whose blood pressures are below 140/90, but above 130/80. So essentially, everything below 120/80, great. Just do usual lifestyle. If it's elevated blood pressure, again, non-pharmacologic therapy, which is lifestyle measures. And then the new stage 1 hypertension, 130/80, but below 140/90, non-pharmacologic therapy, but if the ASCVD risk is 10% or greater, that's when treatment with a medication is indicated. So the vast majority of patients that we will see in the reproductive age group will come in, may have been diagnosed with chronic hypertension based on these new criteria, but the vast majority will not be on medication. And so I think that's something to keep in mind, because the ASCVD risk score even doesn't account for anything less than 40 years old. And then there are other things like, being on medication or being a smoker, etc., that go into that score. And you can Google it and see the ASCVD score, and then absolutely treatment if 140/90 and or greater. This summarizes from that document as well, BP threshold for treatment and BP goal. So you can see pregnancy is not included here, but the goal, BP goal, once you make a decision to treat, ideally for everyone should be less than 130/80. But you can also see two instances here where, in the case where there is the risk, ASCVD risk is less than 10%, then the threshold at which you may consider initiating therapy per se is 140/90. And then that's the same for those who have had a history of stroke. All right, this is what is in that document with respect to pregnancy. It doesn't talk about treatment goals and thresholds. It just talks about what medications to use, and they still had methyl dopa as well. And also what medications we know not to use in pregnancy. So switching gears to pregnancy, we know generally 2% prevalence, but this really varies markedly. It continues to rise with a publication that we were involved in with Anand here, and age and obesity, age at childbirth and obesity playing an important part. I think this audience knows the distinction between what is considered severe and mild in pregnancy. This may evolve over time, but 140, less than 160, 110, mild, and everything 160, 110 and above severe. And we, as we were preparing to submit the CHAP study for consideration to NIH, used some data from the MFMU network and estimated that about 70–80% of these reproductive age patients with chronic hypertension had mild chronic hypertension. We're all very familiar with the risks of chronic hypertension in pregnancy shown here. I think what is most important is just how increased some of these outcomes are. Preeclampsia, 25–30%. Preterm birth, about 38% estimated here historically, and just many more times higher in those with chronic hypertension compared to those without chronic hypertension. And then some of the rare cardiovascular outcomes are also shown here, obviously, just markedly increased in those with chronic hypertension. You can see like acute renal failure 10 to 16 times. And important to keep in mind that preeclampsia is a major determinant or mediator of this increase in adverse outcomes. So moving on to management of and treatment of chronic hypertension in pregnancy, up until, I guess, the last 2–3 months or so, the ECOG document shown here was the go-to and said treat severe hypertension. Obviously, strong recommendation to a goal less than that threshold with labetalol and nifedipine as first-line medications. And then for those without to not have severe hypertension, to withhold therapy or withhold starting therapy if they were not already on therapy. And then if they were on therapy, was unclear whether to continue or to or to discontinue and see whether the blood pressure remains controlled over a prolonged period. And this really represents an evolution from when we were designing the CHAP trial, because at the time, the documents from the 2013 task force, and especially the document from the 2012 bulletin, was actually, those two documents were actually stronger with respect to considering if you thought they had mild chronic hypertension, withdrawing medication and restarting only if the blood pressures move towards the more severe range. Now, I think that evolved over time. Anyway, but why did we have these positions? Because we knew very little in pregnancy. I'll begin with a Cochrane review here from 2018 that evaluated the use of antihypertensive medication in mild to moderate hypertension, moderate using a higher threshold of 170, 110 or less, and in patients with chronic hypertension or pregnancy-associated hypertension, so sort of a heterogeneous group. 58 trials, 5909, so on average 100 patients per se, and some of these were actually secondary analysis. And this figure represents the finding from that Cochrane review, which would suggest that you reduce severe hypertension by treating. And then there are all these other outcomes that may be potentially reduced, but most of them touch one, so not significant. Neonatal RDS in their discussion, although reduced, they indicated this could be confounding by time. So early studies more likely to have these, later studies less likely. And this Cochrane review just again highlighted the need for trials to bring this question to rest. But keep in mind that we are looking at patients who had either had chronic hypertension or had pregnancy-associated hypertension, gestational hypertension, etc. So there were obvious design flaws here in terms of power, publication bias, and the heterogeneous groups. Then there is a systematic review, the only one that we can find, or we could find for a long time, that included only patients with chronic hypertension, mild chronic hypertension, is this review from Dr. McGee and others. 7 trials with 623, again, less than 100 on average, including one that was done by Baha Sibai in 1990. And this is the summary of the findings there. You reduce progression to severe hypertension, but keep in mind this is approximately reducing from about 10% to 5% if you select these patients appropriately. And then perinatal mortality, preeclampsia, some of the material things, abruption, no difference, even though the yellow dots point to the direction of potential benefit. And then when you look at SGA, it's on the other side and speaks to some of the concerns about treatment potentially increases small for gestational age, which itself is a risk factor for stillbirth. And indeed, there were additional systematic reviews here. Obviously, Dr. McGee has done a lot of work together with the husband, von Dadelson, showing that you increase the risk of small for gestational age. I mean, these were observational, meta-analysis of observational studies by using beta blockers. But regardless of the type of medication, as the mean arterial pressure reduced, the risk of SGA and low birth weight increased. So this continued to fit to the concern about SGA and low birth weight with respect to treatment. I like this just to highlight all the guidelines over time that say, oh, we need to study this, we need to study this. And someone, as we were presenting this concept, I think Yasser can maybe recall this, who said, this is the elephant in the room. It's a bread and butter thing. We are not paying attention to it. And so we continue to do that work. But around this time, the CHIPS trial came along, less tight versus tight control of hypertension in pregnancy. And this, again, had a heterogeneous group, and it wasn't focused on treatment versus non-treatment of mild chronic hypertension. Again, it was a heterogeneous group. Patients could get in as late as 33 weeks. They were looking at tight versus less tight, meaning as by default, most will be treated and treated to a goal of tight versus less tight. And as you can see, 75% and higher in this trial actually had treatment. But the primary outcome was pregnancy loss or NICU admission within 48 hours or greater. And there were 94 international sites, less than 70 of these, just over 1,000 patients from a US population. And shown here, the primary outcome, absolutely no difference between group. This could was potentially predictable because the relative risk from the systematic reviews for NICU admission was exactly 1. And looking at that outcome, NICU admission would potentially overwhelm that outcome, which is really what happened. And then the secondary outcome of severe maternal morbidity, mostly driven by postpartum hemorrhage, was higher in the less tight group, but not significantly so. And then the finding of more severe hypertension in the less tight group continues to reflect what was known in the literature, with the difference that the rates were so much higher than had been previously reported. And again, this is because a good proportion of these patients already had severe hypertension. And then it continues to fit to the question regarding SGA, because in the subgroup, again, this is a subgroup analysis with chronic hypertension, the risk of SGA in those receiving tight control was higher. So I think this continued to fit to the need to have additional definitive studies, and SMFM came out with a statement in response to the CHIPS trial that encouraged us to continue to do the work to get findings from CHAP, because we were faced with a situation where treatment, order of the day in the general population, but benefits uncertain in pregnancy and also safety at question. And so that's where CHAP came into place, CHAP being an open label randomized trial shown here coast to coast, red in states that were represented in this study, 70 US centers plus evaluated, and about approximately 61 and enrolling. And it was really a collaborative effort of multiple clinical sites, including obviously Stanford. Primary aim to evaluate the benefits and safety of antihypertensive therapy for mild chronic hypertension during pregnancy. Multiple secondary aims. This is the hypothesis that we address that treatment would, to a goal less than 140/90, would reduce adverse outcomes based on some of the data that we presented without increasing SGA. Only patients with mild chronic hypertension had to be included, either newly diagnosed or pre-existing single pregnancy less than 23 weeks. Those with severe hypertension, so documented severe history of severe blood pressures or requiring 2 or more medications for blood pressure control, likely indicating severe hypertension, excluded, and then several other secondary conditions, including long-standing diabetes. Class C diabetes and Class B were included, but D or presence of end organ defects excluded. Randomization was based on clinic blood pressures. If the patient at baseline was not being treated, then they had to demonstrate an elevated blood pressure in the defined study-defined mild range, systolic and or diastolic. If they were on treatment, they did not have to demonstrate an elevated blood pressure. It could be less than 140/90 if they were adherent to medication. However, if they had not taken their medication within that stringent window of 24 hours, then an elevated blood pressure in the mild range was required for entry. And they were then randomized to the active arm, which meant treating to a goal less than 140 with either labetalol or nifedipine, typically driven by the standards at the clinical site. Other medications could be used, but were not provided by the study, and then titrated accordingly to make sure that the blood pressures remain less than 140/90. In the standard arm, treatment was withheld if they were on treatment. If they were not on treatment, so do not start treatment, or discontinued if they were on treatment. And that's why it was important to be sure that they had mild blood pressure. And then, followed up over clinic visits and treatment reinitiated or augmented if blood pressures, moved to that severe range. And the goal was to keep it below that severe range, though for the most part, blood pressures, once you initiated treatment, dropped to less than 140/90. So this figure just, gives a brief summary of, patients with chronic hypertension, all those with severe excluded, randomized to active versus standard. We followed them for outcomes. The primary outcome was this composite of preeclampsia with severe features up to 2 weeks postpartum, according to ACOG definitions. Indicated preterm birth less than 35 weeks, abruption of perinatal death. And these outcomes, especially the preeclampsia with severe features, obviously centrally and blindly adjudicated. And then preeclampsia with severe features was defined not based on blood pressure. So severe blood pressure, hypertension alone did not qualify. It had to be that plus something else. So that plus proteinuria or worsening of hypertension and any of the signs or symptoms or laboratory abnormalities that we typically would look for and occurring after 20 weeks. SG obviously was used using the DORIA standard, and then multiple secondary outcomes, including this maternal cardiovascular composite and preeclampsia, preterm birth, etc. And a serious neonatal composite as well. The sample size, we followed an adaptive sample size and had planned for that. Our hope was that we were going to have to increase the sample size, but as we went into the study, this is a whole paper by itself. We used that adaptive approach to reduce the sample size from 4,700 to 2,404, and this would provide at least 85% power, assuming a base relative reduction in the primary outcome of 25 to 33%, and assuming a 30% baseline incidence, which is something that was blindly determined by the DSMB during the study, because we had projected a much lower baseline incidence of 12%. It's the whole interesting discussion around this. Anyway, according to current standards of care, we did intention to treat with imputation for a few missing variables. And so quickly to the results published in the New England Journal. As you know, after almost 30,000 screened, and 66% of them excluded because their blood pressures were not elevated at the threshold for them to be able to get into the study, or because they had exceeded the gestational age for entry. We randomized effectively 2,408 at 61 sites to active and standard with follow-up of outcomes up to 96, 97%. And you can see really well-balanced groups. I remember the New England Journal reviewer saying this looks so balanced. But keep in mind about 50% or so of them on medication at baseline, approximately nearly 50% Black majority minority representation here. And then, a high prevalence of obesity in that population, and about 16% being patients who had diabetes. At baseline, at the time of actually randomization in the active group, most got labetalol, a third got nifedipine, and then very few got those medications that we were not going to provide. You can say really very few. And in terms of, this just gives an idea about adherence, because we monitored them over multiple visits. And the bottom line is, just not to dwell too much on this, is that at the end of it all, in the active group, only about 11% of patients who were supposed to be actively on medication were not, which really suggests strong compliance, because the other practically 90% were on medication. And then in the standard group, just 75 or 76% of them were not on medication, again, indicating that the vast majority stayed not on medication. And among the 25%, it's about 10% that were inappropriately on medication, and about 15% met criteria per protocol because of progression to severe hypertension to be on medication. This is a very interesting graph, because it shows, right, though modest, that the two groups really differed with respect to the systolic and diastolic blood pressures over a prolonged period after randomization before, converging as, preeclampsia, deliveries, etc. occurred. I think we all know this. The primary outcome was significantly reduced in the treated group, about nearly 20%, showed here with a number needed to treat of 15 to prevent one of these. But you can still see 30% means we still have work to do. It's reduced from 37 to 30%, but it's still work to do. And this is another way of showing that in a survival analysis. And again, some would argue that this is the most accurate way to present these results, because it takes time in the study to account, and you can see it's still showing about a 21% hazard ratio reduction. And then in the components of the primary outcome, preeclampsia significantly reduced, indicated preterm birth less than 35 weeks, significantly reduced. The other rare outcomes, abruption and neonatal perinatal death, not significantly reduced, but still lower in those in the actively treated group. My summary of this, we can have a discussion about this, but this just in doing this analysis says these results of the primary outcome did not differ significantly by any of the subgroups shown here. We can have a discussion about those who had new chronic hypertension and maybe those who had a BMI of 40 and above, because those had so approximate to 1. But subgroup analysis and the appropriate statistical analysis will say we don't treat them differently. The safety outcome, which was a key concern, here again, no difference for defined as less than the 10th percentile for SGA between groups, and then also defined as less than the 5th percentile, also no difference. And again, for this more severe subgroup, even more reassuring that it appeared it's not much, but lower in the treated group. And then on the host of the maternal composite outcome, no difference, but again, you can see there's some consistency in being lower in the treated group for this rare outcome. And then when we look at other things like any preeclampsia, significantly lower, any severe hypertension, so post-randomization, significantly lower in those who were actively treated. And then the neonatal composite itself, again, not significantly different between groups, but pointing to the direction of being lower in the active group. So some internal consistency there. Preterm birth and low birth weight lower in those who were actively treated. And several other neonatal outcomes, no significant differences, but all again, almost all pointing to the direction of potentially being lower in the active group. So in summary, we see that treatment to a goal less than 140/90 was associated with lower adverse pregnancy outcomes right in the actively treated group, did not appear to impair fetal growth, and no other maternal or perinatal harm, whereas there were a good number of secondary benefits identified, with a number needed to treat of 15:1 for the primary outcome. So CHAP did support the treating to a goal less than 140/90, and especially to continue established antihypertensive therapy. And we, as we're currently working on long-term studies, maternal follow-up study has just been approved by an independent monitoring board set up by NHLBI, and we will follow up those women at 5 to 10 years post, up until 5 to 10 years post participation, and still working hard with NICHD to see whether we can get funding for this or resubmit. When we initially submitted, we did not have the study results. And as you know, ACOG came out within days of this publication of the CHAP findings to say we should change to systematically treating to a goal less than 140/90, or using that as a threshold to initiate therapy. And they said something about, you know, I think not having a precise goal for therapy, but the goal for therapy for CHAP was to treat to a goal less than 140/90. That was clear in the CHAP protocol. And then SMFM, as you know, also came up with similar policy recommendations to change to treat to a goal less than 140/90 as well. So obviously want to thank NHLBI for funding, and people, including those like Dr. Dudley, who did a yeoman's job with the DSMB with multiple questions along the way many of you here, faculty, trainees at sites that made this all possible, and obviously the clinical, the research teams as well that make it all happen. So I'm going to pause here, and it's a really big team. This is just part of the team, but it took a village, and I thank you for your attention.
Thank you so much, Alan, for this wonderful and comprehensive review of this practice-changing study, another practice-changing study. I will open up for questions that folks may have. I have one of my own, but I'll save it for now and just see if any questions come up. Yair.
Hi, Dr. Tita. That was phenomenal, and congratulations on such an amazing study. I know how passionately and hardworking Yasser and the rest of the team here worked to be a part of it, and it's an honor to see it from the sidelines and to really see that it changed management. So congrats to you and the entire local CHAP team.
Great. I second that. Thank you. Yeah.
And just as I'm going to ask you to extrapolate a little bit. Has this changed how you personally manage gestational hypertension after 24 weeks? Like when women have new onset, hypertension that doesn't quite meet preeclampsia and they're a little over 140/90. What's your approach there? I know it has nothing to do with CHAP, but I was just curious as a savant in hypertension and pregnancy, whether that has changed your thoughts on that.
Yeah. No, yeah, that's a really great question, and consciously it's not changed. I think it's a different population. I know subconsciously things may happen, and so I think that's a question that is open and out there. We've had some letters sent to us that speak to that, and we've responded that we don't think there may be additional studies or analysis that we do to speak to that, but we don't think that we ultimately provide the best evidence for that. And I have a mentee who just recently got a K23 that will be looking at, I've already proposed this to look at a question along that line for gestational hypertension and even preeclampsia, mild preeclampsia, should we be treating them? And there is a group, at least even within the CHAP consortium, that's interested in that question. I know there's a meeting scheduled to look at that as a potential question for another trial. It all depends on whether people think that there is enough there and an important group to get a final a recommendation done. I know there are people on both sides, so it seems like a viable question.
Thank you.
Thank you.
Alan, thank you so much for a wonderful talk. But I think, consulting with a lot of private doctors and people in practice, generalists, this is obviously a practice-changing study, but they are going to ask what target, what is the target? Because telling people just to be less than 140/90, it's kind of leaving it very much open to an individual approach. Now, some people have said we should be targeting 120/80. And the question is, at what point do we start running into the SGA issue? The CHIPS trial, was a kind of one that was very nebulous as well. And so people were very confused about the goals. So I'm just asking you as a clinician, if tomorrow one of our referring physicians calls me and says, the new CHAP trial, you guys are all excited about it, but where does it stop? I started on labetalol 200 and she's 130/80. Is that okay? Do I need to go to 120/80? I think we do need some guidelines from our professional societies, but I'd also like to hear from you how you would approach that if tomorrow one of your referring docs called you.
Yeah, really great question. And so just sticking with the protocol for CHAP, and I know there is some CHAP co-authors, a initiative underway to make sure the protocol gets out there to addressing some of these questions. But sticking with that, we said keep it less than 140/90. But once you start getting to 90/60, you really have to consider, backing off on the treatments or stopping them. I would back off rather than stop, especially with labetalol because of the risk of rebound hypertension. But also importantly, regardless of what blood pressure below 140/90, if they start developing side effects consistent with the blood pressures being low, then that also should give pause to consider reducing the medication dose. That's what I would say with respect to the CHAP protocol. Now, whether we go with 120/80 or we go or 120/70 or we go with the 130/80, I think remains an open question. And is that the next frontier? Does it take a trial or does it take some implementation work? I would say we are doing additional analysis in the CHAP cohort that will be presented hopefully at SMFM next year. Seems far away. That will speak to what happened, especially with respect to outcomes, depending on where the blood pressure stood for patients in the CHAP cohort. But that's also another idea that is being batted around as a potential trial in itself. Should we now, instead of 140/90, do a trial that compares to what everyone else is doing in the general population to keep it below 130/80? Yeah.
Thank
Thank
you.
you, Alan. I think Ron Gibbs has a question for you.
Alan, kudos once again on a masterfully done study. My question is, were the results consistent across centers, across regions of the country, and across racial ethnic groups? I know you were empowered to look at that, but do you have a sense?
Yes, so we did do the subgroup analysis, and the racial ethnic analysis was one of the key ones, and the results were actually, in fact, more consistent than within the with respect than the hypertension types. This wasn't mentioned in the paper, but we did for NEJM an analysis that looked at it by effect by sites, and really did a elegant statistical analysis from our data team to show that overwhelmingly the results across sites were consistent. On the margins, you could see some differences, but I would say statistically about 90% or so results were internally consistent by site. Thank you.
Great.
Thank you so much. Alan, I think you touched on the question I was going to ask, which was, is there thought to doing, I mean, I'm sure it strikes fear into everyone's heart given how hard this study was, another study looking at a lower threshold, the 130/80, the 120/80, and it seems like there was at least some discussion around that. But this was a mountain to climb to do this study, so it certainly is not something that would be taken on lightly, obviously.
Yeah, that's very true. And so those two, I think, are the two questions. What do you do with it? And even with those with superimposed preeclampsia, do you treat them now to the same goal, or do you not? That's one. And then what threshold to treat to? I think that continues to be a burning and this question for discussion. We, as you know, we are developing some preliminary information internally as well. So it looks like, especially with that 30% in the active group of the primary outcome, the work is not close to being done. Yeah.
Well, we are right on time. Alan, thank you for such a efficient and clear and succinct presentation. And for those of us going to SMFM, I know there's going to be abstracts presented on secondary analysis of this study, and we'll all be learning more. And congratulations again for this phenomenal achievement. I know I speak for everyone at the Dunlevie Center in the audience that we look forward to having you again. I am sure in the future talking about other studies and investigations that you are doing. And thank you for all the work that you have done and that you do in our specialty.
No, sounds great. No, thank you, yes, sir, and thank you to the entire team for the ongoing collaboration. Thanks again. Have a great day.
Wonderful. Thank you. Thank you all.
Bye-bye.